So it's almost like, having a magic 8 ball and being able to, see into the future. So that's, the huge change that's occurred, just in the last couple of years.
That's Dr. Tara Graff, a medical oncologist for Mission Cancer and Blood. She'll be back later in the show. Today on Cancer Buzz, measurable residual disease testing and the promising outlook for its broader applicability. What you need to know is next. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Assays for measurable residual disease, or MRD, can identify extremely small numbers of remaining malignant cells after treatment and are ideal for blood cancers such as multiple myeloma or CLL, detecting 1 in 100,000 or even 1 in 1 million using next-generation sequencing or next-generation flow cytometry. There's a growing interest in using MRD testing as a more effective prognostic biomarker, although its applicability to additional cancers is being studied. Dr. Rafael Fonseca is a professor of medicine at the Mayo Clinic in Scottsdale, Arizona. He specializes in multiple myeloma. Dr. Fonseca, how long has MRD testing been available for patients with cancer?
When we talk about MRD, we're talking about one of the various tools that are available to measure with great sensitivity the presence of residual cancer cells. In many ways, this has been available for many years for individuals who treat patients with the various conditions where this is applicable. But truly, the refinements that have occurred over the last 5 or 10 years have brought it to the forefront, and also in a very timely way, because now we have the treatments that are able to reach those very deep responses where the question matters. For many of the cancers in the old days, we would treat and we would be happy with a partial response, and we know the patient is, deriving some benefit, but measuring things like MRD was of no value. But now as we have patients that go into complete responses, some of them which are very durable, with or without the immunotherapy, we clearly needed better tools to measure the depth of that response. So I would say it has come to the forefront in the last 10 years, but very intensely now in the last 5 years. And I think it's here to stay.
What's the most frequent use of MRD testing in practice?
Depending on the disease that you're applying the MRD for, you will have different questions. But in general, you would do MRD to first gauge the depth of the response after a line of treatment. So in my particular case, in multiple myeloma, we do that after induction therapy, for instance, or after the stem cell transplant, where we just want to have very precise information of how deep down we were able to attain a response. So that would be the first one. And that has various uses, widely accepted, supported by 3 meta-analysis, unquestionable. It's the most important prognostic factor for multiple myeloma. There's a growing field where people use that information to think about additional therapy, myself included. So I use this in my standard clinical practice in such a way that if someone remains positive, I have a conversation with patients about the pros and cons of additional and particularly different type of therapy as we go through those steps. So that would be kind of the first one. The other big one is to use it in patients who have long-term sustained complete responses. First, for the reason that we can discuss this with patients, is important information. But second, also to think about part of a more informed conversation where we can think about therapy discontinuation. So those are the 2 big uses that we have right now for this MRD testing. I'm sure they will expand as we go into the future.
Has the testing been incorporated widely into clinical decision-making?
Not yet. I think we have significant room for improvement on how this can be integrated into the decision-making in our clinical practices. Part of this is, it's a little bit strange, but MRD has been treated somewhat as an exceptional thing where it's just a better tool, right? It would be like we would need to have a conversation when we went from MRIs that were 3T versus, 5T or 7Ts, whatever it is the radiologists use now. The same happened with myeloma. We kind of went from the protein electrophoresis, then we measure free light chain. And it's just that sometimes there's this perception that it needs to be treated differently, but it doesn't. It's just merely a more sensitive tool that can help us gauge how deep the responses are occurring for our patients. And of course, we need to understand all the implications. I think there's research going on understanding, okay, what do you do if, this happens or that? But the reality is this is no different from any other biomarker we use in oncology.
How does this differ from previous assays you used to detect cancer cells?
If you think about cancer and how we monitor it, and you go to the most, crude or, rough way to do that, it would be through imaging. And the reason is in imaging, you might see nodules or you might see masses, and what you're measuring is usually things that are in the range of about, half an inch, sometimes bigger. You can sometimes see smaller nodules and you would describe them as such, but you essentially have no ability to measure that. And we really have to move forward towards measurements that are more precise and are deeper. We have other biomarkers, some of which are, helpful, but oftentimes they don't provide the whole set of information that we need. Tumor markers like, PSA, CEA, etc. In reality, what MRD does, it brings together the specificity of what we're measuring alongside with sensitivity.
What's the current evidence of usefulness of MRD testing in myeloma patients?
I have been doing this now for several years, probably more than 5 years now. And if you were to ask me, do you know what you were doing before? And I would say, boy, my practice is so different. And it is so different because of the understanding that is provided to me by the ability to measure this. One could think about it this way. Think about, the ocean. And when we use our traditional methods of measuring proteins, we kind of are left at the surface of the water. But there's a lot of depth underneath that. And that's what MRD allows you to discern. Importantly, by the way, I should say, the MRD testing provides a quantitative and continuous variable number that you can use to track progress or perhaps even recurrence. So when I talk about someone who has a complete response, that I have no protein markers that I can measure, and 10, 15 years ago, we would tell that patient, boy, this is great, we have a complete response, no evidence of cancer. But we know we're just touching the surface of that ocean. Now that we go deeper, we know if indeed we're at the bottom of the ocean, or if we are somewhere in between, that again, it might deserve additional treatment or might indicate, if over time it progresses and it goes upwards, that perhaps that's the early sign of a relapse.
Is there anything that we should keep in mind when we're thinking about MRD testing?
The one word of caution, and this is important for people to know, and this just stems from very simple logic. You cannot prove a negative. Even though you have an MRD test that is 0, you cannot categorically state that there is evidence that there's no further disease. What you just have is a test that is negative. But you cannot 100% say that there couldn't be disease for multiple reasons, sampling or, there's tumors in other areas and so forth. But we know very well that if you reach this very deep level of responses, you actually are prognosticating a future that will be much better for those patients. So again, I think there's quite a range of opinions on how much you can act on this. I think it's clearly moving more and more towards being fully integrated with our clinical practice. But if at the very least, and this is unquestionable, if at the very least you have a conversation with a patient that has this MRD negativity and you explain to them what it means, and you're familiar with the data that comes out from this 3 meta-analysis, I mean, this is incredibly useful information. I can't tell you a number of times patients have told me, I cherish my MRD negativity. You don't know what peace of mind I have knowing that I am MRD negative. Now, there's another side of that coin too as well, is because the conversation is very explicit. There are some patients that, become disappointed because they don't reach that point. But even then, I would always argue more information is better. And, the ability that we have to tailor that to the individual situation is quite unique with the measurement of MRD.
Some have said that MRD has become the most reliable marker of treatment response in patients with myeloma. What's your reaction to that?
Completely agree with that. We know that at high levels of tumor burden, we can still measure the proteins like we do with the protein electrophoresis, we do with the quantitative immunoglobulins, we do with the free light chain. But then very quickly, they go into a range where they no longer hold ability to discriminate further response or not. That's usually around 0.1 or 0.2 grams per deciliter on the protein electrophoresis, and usually in the normal range for the free light chain. So that's about 2 milligrams per deciliter. Once you go to that level, then you're navigating in the dark if you're not doing something like MRD testing. In fact, I have seen now cases where I know our pathology colleagues, the expert pathology colleagues, may have a hard time knowing where there's a monoclonal protein, or what we call an M-spike, or not, in patients who are previously known to have a monoclonal protein, and that subsequently, through things like mass spec or through MRD testing, we know the patient does not have evidence of residual disease. And that just speaks to the difficulty that the standard laboratory technique has in differentiating those very deep level of responses. So you can use that as you get going. We use that all the time. It's part of routine clinical practice. I would never advocate we don't use that because it's an important first set of steps. But then once you reach that very deep response, then you must use the MRD to continue to guide and assess the worth of your therapy.
Well, what about cost? Is it even covered?
Yes, so there's various tests, and flow cytometry, for instance, is a test that it's available widely at different laboratories. In fact, people can have access to that, and if they have multiple callers, they can even use the Euroflow at high sensitivity. Some of this are this laboratory-developed tests, but for the sequencing one, so we have an FDA-approved test, which is a clonoSEQ assay, and this clonoSEQ assay is FDA-approved and is covered by CMS, so that is there. I will argue that when we talk about cost, which is, by the way, another one of my favorite topics, as we were just talking with some of our friends before, one has to look not at the unit cost of the intervention, the treatment, or the diagnostic, but at the total cost of care. And if indeed our wildest dreams come true because of MRD testing, I can see where there's a future that A, we have the treatments that achieve MRD negativity in the majority of patients, but B, also those treatments will allow this continuation of therapy. And C, they will prevent complications such as, disease progression, fractures, need for surgery, need for hospitalization. So it's not too far-fetched to put a hypothesis that the best therapies accompanied by the best diagnostics will ultimately not only save lives, but it will also save money.
You heard from Dr. Tara Graff earlier in the show. She's a medical oncologist at Mission Cancer and Blood in Des Moines, Iowa, and she specializes in CLL.
Prior to just recently, we had MRD testing available, but it wasn't as sensitive. So you were talking about 10 to the minus fourth, which is still a lot of the traditional assays use 10 to the minus fourth. But now with some of the newer assays like clonoSEQ, we can detect minimal residual disease down to 10 to the minus 6. So we're talking way before any laboratory value would pick up anything, before any scan would pick up anything. Heck, before a patient would probably even have a clinical inkling that something was going on. So it's almost like, having a magic 8-ball and being able to, see into the future. So that's, the huge change that's occurred, just in the last couple of years. I have a big background in bone marrow transplant, and we were doing MRD testing back then, for our transplant patients, but it was nothing compared, to the assays that we have now.
How are you currently using MRD testing specifically for patients with CLL?
I would say for CLL, it's being used more in ALL and in multiple myeloma as well. But for CLL, we are in this day and age of fixed duration of treatment. So for some of our patients, we're choosing regimens that, actually they can get off of in a year if they're MRD negative versus, treating to progression or intolerance with other drugs. Now, a lot of that goes into selection. We choose our treatment for different patients for different reasons. But, it's a good assay to use when you're talking about a fixed duration therapy. It's also used, and I don't want to speak too much about the other disease states because those are not my areas of expertise, but in multiple myeloma, it's helpful. Prior to MRD testing, for myeloma, we relied on marrow and we relied on these, VGPRs or, VGPR, very good partial response. And now with using the MRD, we can really see, okay, if a patient's laboratory values show that their light chains, for example, are going up. Well, are they going up because of something else going on in the body? Are they going up because they're on Revlimid, or are they going up because there are truly plasma cell clones back in the marrow? And so you can do an MRD test and you can find that out without having to, do a bone marrow every 3 to 6 months if something's going on in the labs. So it's really sparing our patients, unnecessary scans and procedures, in the right setting. I'm not saying one size fits all, but in the right setting with the right question in mind, it is helping us, make those decisions.
Is MRD testing very common, or is it even being utilized in the community setting?
It's not mainstream. Not every, clinic or lab is doing MRD testing in all of their myeloma and ALL and CLL patients, because it's just not something that's being readily used, by community oncologists and such. It's, used a lot more on trials. And I think it's just starting to make its way into, mainstream in different practices. But I know that I practice in a large community oncology group, and I traditionally practice more like an academic physician, which is where my background is and where I came from. So I rely on it a lot more. But I know that out of the 17 of us, there might be 3 of us that will do it, and me more than anybody else.
Has it been shown to improve outcomes?
I don't think we know that yet is the problem. I don't think we know that yet. I mean, in a trial setting, yes. In mainstream, just everyday use, we don't know that yet. It's not being used widely enough off trial to really say that right now. And I think that's what the argument is, and that's what we're having these meetings on, is how do we get it used more? How do we get physicians more comfortable with using it? How do we interpret it? Do we know how to interpret the data? How are we going to use this data? Is it going to be useful? Is it going to make an impact? Is it going to change outcomes? And I mean, I think from a basic science setting, yeah, it's going to change outcomes, because you're going to be able to catch disease progression and make a decision on your patient before it's all over.
When you're having discussions with your colleagues how to better utilize MRD testing, what are some of the solutions that have come up in terms of training or education that's necessary for the members of the multidisciplinary team?
Knowing when it's appropriate to do it, not everybody who walks in, say a, stage 0 CLL patient with good prognostic factors comes in, you're not going to do MRD testing on that person. The likelihood of them having disease progression or any kind of concern is very, very low. So you have to know when to utilize. There has to be a question. Okay, is this patient progressing? Let's do this test to see. So what happens is, if I have a patient with high risk disease, well, I'm using CLL as an example. They have an unmutated IGHV. I expect that they're going to need treatment either right away or sometime in the near future. I'll get like a baseline test on them to measure clones, to measure clonality, and to measure sequences. And then if I start them on treatment, I may do a test at 3 months and maybe at 6 months, but I'm not getting one every single time I see them. You can't overutilize the test. So you have to, I think, know what your question is, who your patient is, and how to follow it.
How have you trained your staff?
So there's some training of the care team in terms of who the pinpoint people are who are going to be sending the test out, how to do it, where it goes, how it's stored, the proper way to send it, temperatures, all of those things. So, we had a lot of education in our office led by me, my nurse manager, lab manager, and a couple other people to really get the facility on board with knowing the right top, the more, just the storage, all of that stuff. And then really I did MRD training. So I know how to interpret, like the clonoSEQ assay. I actually am one of the people who was trained on how to, help other physicians across the country to interpret. So for me, I help my partners when they order it if they have questions. But, you usually have a pinpoint person, not so much necessarily within your group, but, that you can contact if you have questions.
You can check out the show notes for more information and resources on MRD testing. We know your time is valuable, and we want to thank you for supporting Cancer Buzz. Until next time, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.